Okay, so as some of you may know, we're trying to institute a change in the rapid response team policies and procedures, just to better implement faster, decision to implementation to an intervention times. Right now you guys have your hands tied for when you have an RRT call. You get there, you do your assessment, and you make a call to the doc, and you're waiting for him to call or her to call you back and let you know, hey, you can do this, let's do that, or you guys make the decision, it's out of our care, range, and they need to go to the hospital in an event like that. So you're either waiting till it gets worse, or you're waiting to get something to do from the doctor. So we're trying to decrease the time and give you guys some interventions to implement. And on that sheet right there, it looks like this little guy here says rapid response team protocols. This is just a list of interventions you can do that you can kind of, make your critical care decision there of which one to apply, how to apply them, and when to apply them. And those are some pre-approved interventions that we've kind of come across. We've also changed, instead of having your standard airport AED, we've upgraded to the Zoll defibrillator here. It's got your normal AED mode. You have an RRT call, you can turn it to AED mode, same setup. It'll tell you or talk to you, prompt you, just like an AED. You can also switch it over to manual mode. The button's down here, confirm it, and you get a whole bunch more buttons. You can change your leads, you can charge, analyze, synchronize, all those good things. This thing's down here. You can time mark your events during a code summary. Oh, we gave epi, or we gave whatever, but stuff like that. You can time mark the event, start at CPR now, and then in the end of it, you print your code report. You can attach that to your rapid response team summary sheet, and that goes with the chart and makes it pretty easy there. Another neat little function this little guy has, particular to this unit, is during chest compressions. If you look at the rhythm and you're trying to analyze that rhythm, well, during chest compressions kind of makes it difficult. Well, this thing tries to tone out that interference, so it picks up the rhythmic compression cycle and phases it out. It's not 100%, but it gives you a better picture of what's actually happening, so you don't have to stop and go, oh, what is that? Okay, and keep going. You can actually see the rhythm progress or decline as you keep going, and then you can kind of manual mode. Yeah, we're good there. And then up top we have your green check, which will be the indicator for your time checks, like checking your crash cards in every 24-hour event, and it'll be like the charge nurse or the shift supervisor who comes in and does it. Green check mark, you put it in, you test the AED, and then it'll stay green every 24 hours. It flips back to a red X, signifying that you need to just test it. And that's pretty easy. Just go into your options down here, and you can go and test it all. That's pretty much the basic setup there. The 3-lead, you have your little connector here. You can pop this off from your AED mode, disconnect, attach these. You can connect them to, do we have the 12-lead thing on the attachment? Okay, no, okay. And so you just do your 3-lead and you get a quick rhythm interpretation, and you're actually able to change leads when you're in that. You can get a little better picture from 1 or 2 lead, just to confirm like a fine VFib or something like that. That'll help you, instead of just where before you're hooking up an AED and they're like, oh, well, they're, having some shortness of breath and something's going on, but, AED says, no, we're okay, no shock advice. Well, now you can actually call them and be like, hey, we're a flutter or SVT, give them a better picture when you're calling, give them a little more, confidence in, hey, this is what we're doing, this is what we're going on, and they don't have that knee-jerk reaction to send patients out, which is what we're also trying to decrease here. Keep them in-house, make more money, so on and so forth. So just turn that guy off. Also, so on top of the crash cart, you'll have your suction, you have your telemetry, you'll have your crash cart log, which will be signed, stuff like that. This will be locked, and then the drawer with the first item to expire will be labeled and timed, and it'll be, like it's in this drawer, it'll be like, yeah, oh, it's the nasal cannula or whatever, just put it in there at the daytime to be on that. And you have your backboards, your O2. But we're going to make some changes as well to the crash cart. The top first drawer will have your medications, and on that protocol list you have some medication listed there like Lasix, some Narcan, stuff like that. Those will all be in the first drawer, and you can make access to those. Your second drawer is your IVs, stuff like that, and then so on and so forth. Your third, fourth drawers would be fluids, and then your extra items where you have your extra OPAs, and then a secondary AMBU bag, another set of AED pads, stuff like this, another Yunker for your suction kits, and that's pretty much it. And the rest runs pretty much the same as it is now, just this top drawer will have medications, and that'll go through pharmacy. If you have a code, you use it, you take it back to pharmacy, which I'm sure you all experienced at some point. They restock it, relock it, put it back. And so, like I was talking about, you can see your rapid response team protocols there. They can tell you, when, what to do, and just some, possible ranges of stuff you can implement. Obviously it doesn't fit the patient, we don't use it, but this way, say you have a call with your standard CHF patient who, for some reason, is fed up with you not giving him all his Gatorades that he wants, and has hammer-fisted 10 bottles of it in the past 24 hours, and you're like, oh, well, we got an issue here, he's having difficulty breathing. Before we would have to call the doctor, wait, or have a doctor come see it or whatever, and then, oh, okay, maybe we can give him some Lasix, or maybe we send him out just because it's so bad we're not really sure. Well, on there we can actually go ahead and give 2 rounds of a Lasix dose, and if they start making urine, or that resolves a breathing issue, and we can look at their heart rate now and actually see the rhythm and be like, rhythm's fine, O2 stats are fine, blood sugars are fine. We just need to pee out some of this fluid that we've been drinking Gatorade bottles all day from. And he starts, patient improves, and now we don't have to send him out. We don't have to, oh, okay, now we need to, further eval. We don't have to sit here and wait 20 minutes while he further declines. We can give him that Lasix right then, and then wait the 10 minutes for him to pee or whatever. Start moving towards the direction of patient improvement a little bit quicker. And then on there you'll see there's also, you have your protocols for your crash cart, who is responsible, when it's done, how it's done. You're going to come in every 24 hours, you check your AED, make sure it's green check, not red X, charge it, discharge it, and then you write your initials, the time, same as you would in a hospital or anywhere else. You put it down in the log, you did it, what the result was, you check the numbers off the crash cart, you write those down, and then you make sure your suction and your O2 are functioning and all like that. And it's try to keep it short. It's pretty basic. That's pretty much it. You guys have any quick questions or long questions? We're open there too.
When are we going to be moving to this?
Pharmacy is going to have to get the medication drawers ready, and we'll be sending the crash cart, the updated crash cart policy through the quality council coming up, because one of the things, like right now, the way that we check the crash cart is a little bit cumbersome in that once a month the night charge nurse has to go through the entire thing, and there's supplies on there. We've got pediatric supplies on there. There's no reason for us to have pediatric supplies because one of the things that I did do this year is I changed our scope of practice so that it says 14 and over. So because 10 years ago you could take care of a pediatric patient and it wasn't that big of a deal. Now under the new requirements and everything, if you're going to do pediatric care, you've got to show education for that, and we really and truly are not equipped to handle that that population. So we're going to be doing a complete inventory, and we're going to have kits put together where we'll actually have our IV supplies will be in a box that will be housed in one of the drawers, so that when we do call, we call a rapid response, which is our doctor stat or whatever you want to call it now, that the expectation is that respiratory, the charge nurse, and the supervisor all respond. They are responsible for doing that initial assessment to make a determination of how we need to proceed. Because especially at night, there isn't a physician in-house, and we've all had the challenges of when you've called, you don't get a timely response. So the way that this protocol is written, and the protocol has actually gone through the medical executive committee and has been approved, that if we don't have a response from a physician within 10 minutes, or it's a truly emergent situation, we can go ahead and initiate some type of intervention. and make that determination if that patient needs to be sent out or not, without having to have that physician order to do it. And, you know, because I mean, we've done it before where it was, you know, a code, which is totally different. I'm talking about the ones that are in acute distress, that we need to intervene now to try to turn that patient around versus waiting, you know, 30, 45 minutes for a physician to call us back to make a determination of what we can do.
So I can order Lasix if I see my patient in the.
If you have to have, you have to call the rapid response team. So in essence, you would hit that emergency button, just like we would in a code. People would respond, and your supervisor and the charge nurse collectively are going to make that determination of how to proceed.
Okay.
Because what I would like to see occur is, because one of the issues we have, and this happens a lot, we send a patient out, and then, you know, the next day we're looking at it and there's no assessment. So the way that this protocol is written, the charge nurse and the supervisor, one of the two of them will be doing a full assessment of that patient, and they will be responsible for documenting that assessment to facilitate that intervention.
Yeah.
Does that make sense?
Yeah.
And I think
Great idea.
because one of the things that we have done this last year, all of our supervisors are required to have ACLS. And the reason, and all of our supervisors, every one of them has a critical care background somewhere along their, you know, in their nursing history. So they are supposed to be equipped with the knowledge to make a clinical judgment in terms of how to treat that patient. And we're not practicing outside of our scope, because we have outlined, we've said that, you know, if a patient has chest pain and a physician has not called me back, we can go ahead and initiate this protocol under a rapid response. Now, if I go in and my patient has chest pain and I say, oh, well, you know, they're having chest pain, I'm gonna go get them some nitro, that doesn't work without a physician order. You must initiate your rapid response team. And then if they come in and I'm having atypical chest pain where I'm diaphoretic and I put them on a monitor and I can see that they're having EKG changes, then yes, we could go ahead and initiate that. But if I go in and they're just saying, I have chest pain, you know, 5 out of 10, but, you know, they're not having any shortness of breath or anything like that, then we do have time that we can say, okay, well, let's get an EKG and, you know, we can do some other things. But if they are looking like they're symptomatic, then we need to start with interventions sooner than later.
So charge nurse and supervisor must have to respond if you call them. Okay, that would happen. Now give me a look. I had those issues.
We want to make sure that we're utilizing the resources that we have wisely. And so I know that we've had some, I think for the most part, our supervisors are very, very good about responding. But I know that we've had some issues in the past where we've had emergent events and nurses have felt like they were kind of dealing with things on their own. But you call a rapid response team, I mean, and that's what Dr. Stat has always been there for. You call a rapid response team and you're going to be getting somebody. And it may be that you go to the charge nurse and you say, hey, I'm really not sure about this. And your charge nurse goes down and says, let's call a rapid response team. And you call a rapid response team, you're gonna have respiratory and a supervisor there pretty quickly. And then if there is a physician in-house, they'll show up too.
No more questions.